A young woman comes in with sudden onset unilateral weakness, but the CSF findings are negative, and they also display some constitutional symptoms like fatigue. On lab testing, you see thrombocytopenia. They might even have a little mitral regurgitation, such as a holosystolic murmur at the apex on exam, and they also test positive for anti-nuclear antibody, or ANA. You should be thinking about antiphospholipid syndrome in the setting of systemic lupus erythematosus. Some major clinical features you have to remember is that these patients can have venous or arterial thromboembolic disease and very adverse pregnancy outcome. For thromboembolic disease, you think of DVT, pulmonary embolism, ischemic stroke, and transient ischemic attack. When it comes to pregnancy, some of these patients have very unexplained embryonic or fetal loss. Patients with antiphospholipid antibody syndrome may also have premature birth due to placental insufficiency or preeclampsia. Remember that on laboratory findings that the lupus anticoagulant effect has a paradoxical activated PTT prolongation, despite having thromboembolic disease risk. When you have plasma mixing studies, the prolongation does not reverse. They also present with specific antiphospholipid antibodies like anticardiolipin and anti-beta-2 glycoprotein 1 antibodies. Now what happens if a patient comes in, they have a cerebrovascular event. The patient is also young, but in this scenario, the CSF shows lymphocytic pleocytosis. I think at this point you should start thinking about neurosyphilis. These patients can have false positive RPR tests. On that note, antiphospholipid syndrome can also have a false positive RPR test. This is because the syphilis antigen used in RPR testing contains cardiolipin.